All right, go for it.
All right. Welcome, everybody. My name is Jennifer Sayani, and I am the Marketing Communications person for Delaware Hospice. Delaware Hospice is a whole organization as well as a program of Delaware Hospice, and we also have another program called Delaware Palliative. And today our guest speaker is Mandy, who is one of our nurse practitioners with Delaware Palliative. So Mandy, you want to share a little bit about yourself?
Sure. My name is Mandy, or Amanda Donaway. I'm one of the nurse practitioners for Delaware Palliative. I have been with Delaware Palliative since 2000, well, for a year this past August. I actually was in training with Nicole. We went through orientation together. So I do Delaware Hospice too. I do all the medical on call, do the face-to-face visits. So I do know, learning about the Delaware Hospice side too. But I do 32 hours a week. I do every Monday, Tuesday, Thursday, and Friday. So I do enjoy it. I actually have fallen in love with it. So I'm learning every day. So I enjoy it. I've only been a nurse practitioner since 2018. So I'm a fairly new nurse practitioner. So I've been an RN for 19 years. So I'm not new to the medical world, but new as a provider.
Well, thank you. And thank you for joining us. And that is a great point that you bring up, that you work in both fields. As we go through the presentation, I hope everybody will learn and see that there are two very distinct aspects to hospice care and palliative care. So it is nice to have Mandy with us today, who works on both sides of that spectrum. So for the next 30 minutes or so, we're going to have a discussion about palliative care and hospice care, how they're similar and how they are different from each other. And I encourage you guys, if you have any questions, you're welcome to either raise your hand or put them in the chat box. If you go down to the bottom of your screen, you hover right over in the middle and you can see the chat box icon, and it will pop up. And you can let us know any thoughts, anything you would like to share. We'd love to have that. So to get us started, I would love to do a poll. So if Vanna, Nicole could, there we go. Have you or any of your loved ones received palliative care? So we're starting off with this question today, just because we are finding that a lot of our community members and even our medical providers in Delaware are a little fuzzy on what exactly palliative care is and what it entails. All right, okay. So about 63% of everybody who took the poll has not had any personal experience with palliative care. And about 13% of you are just not sure, and that's great. So welcome, and I hope we can flip that poll at the end of this conversation. So let's go ahead and dive right in to what exactly is palliative care. So palliative care, the definition is to soothe, and it is typically a specialty of care. And now I'm going to turn it over to Mandy, because she can definitely articulate this a lot better than I can. So can you go through a little bit of what a palliative care might look like for someone?
Sure. So, and I do have my notes, so I apologize, got to read them. So palliative care focuses on providing relief from the symptoms, stress of a serious illness. So our goal is to improve quality of life for the patient and the family. So we work with the patients and doctors to provide an extra layer of support. It's appropriate for any age at the stage of a serious illness. It can be provided along with curative treatments, such as they can be receiving, and this is where it's different from hospice. They can, while they're getting palliative care, they can be receiving chemotherapy, iron infusions, dialysis, radiation treatments while they're getting our services. So if we get a referral that comes in to manage, I'm just going to give you a few examples for managing congestive heart failure. So we collaborate with their cardiologists, for an example, and if they don't have a cardiologist, we look at getting a cardiologist for them to do symptom management of, of edema, swelling of their ankles, and any of the associated pain that goes along with the swelling. So, we educate them on how to stand, sit, lie down to improve their breathing, training them on the use of fans, relaxation methods, meditation, breathing exercises, and also ways to decrease their anxiety or panic they may have. Because, when you're short of breath, first thing you do is get anxious. And it creates a lot of anxiety for the patients. And also with, the side effects of having the edema and, you're filling up with fluid, you're going to have coughing. And, we do a lot of medication management, a lot of education to the caregivers. And we also try to prevent, readmissions into the hospitals. So we don't want them going back in there. Providing, get them with the scales and learning how to record their weights. So that's just with, congestive heart failure. Then COPD, we have a lot of those. So, the biggest thing with COPD is with inhalers. A lot of them do not know how to use their inhalers properly. So getting them on a schedule of using their inhalers, their rescue inhalers. A lot of them overuse it and don't know how to use it properly. Then we work closely with our pulmonologists. A lot of them don't have a pulmonologist, so we do try to get the referrals out and get them in with pulmonology. And having a chronic illness like COPD requires lifestyle changes. So let me turn this page here.
So it sounds like,
What's that?
I was going to say, so it sounds like what you and your colleagues do is really become the liaison between the patient and the family with all of the different doctors they might be seeing. Because typically someone's not just seeing one doctor, they might be seeing the cardiologist, they might be seeing the wound doctor, they might be seeing a nutritionist, and you really are, working to bring all of that information into a cohesive
with a collaborator. Mm-hmm.
Yeah.
We come in and we do a lot of collaborating with all the physicians, and lots of times the patients need that. They don't want to do that. And, you've got their primary care doctor that's prescribing one medication, and then you have their specialist that's prescribing another medication, and they get very confused. Mm-hmm. So, and they don't know how to, like with having the COPD, they don't know how to use a lot of their inhalers. They have no idea what it's for. And, with the rescue inhalers, they have no idea. So, it's a battle, and it does create a lot of anxiety, and, and they get very depressed. Depression is a big thing. And then it creates a lot of social isolation. They stay in the house, they can't get out because they can't breathe. So it's hard for them to walk out the door and go see family. Even taking a little car ride sometimes is hard to do. So, right. So it's really a lot of symptom management is what we do. A lot of education on nutrition, and having the COPD is, that's a lot of it too. They get very malnourished. So, making sure they eat enough protein.
And I'm sure that you're working with the patients and providing that comfort and that support for the patient, but I'm sure that you're also affecting the lifestyle and the anxiety of the loved ones that are in the house, or maybe who aren't necessarily in the house. Especially
Right.
with COVID going on, family members might not, and friends might not be able to get in to see that person. So providing that knowledge and education for their loved ones as well.
And some of them don't have loved ones. Some of them don't have family. So, they require more visits,
Right.
more monitoring going out there. And, and then we have a social worker that goes out with us and, because for palliative care, that's what our program is a social worker and a nurse practitioner. Then we will go out there and provide resources, for aides, and we will give them, those resources we'll provide and try to see if we can get them qualified sometimes for long-term Medicaid and, transportation and those type of services. We'll see if we can. So we try to bring in the extra resources if available for them.
And speaking of that, one of my first patients that I interviewed when I joined Delaware Hospice 5 years ago was a Delaware palliative patient. And she was having difficulty getting to her doctor's appointments because she had stairs coming out of her house. She wasn't able to maneuver the stairs anymore. And the social worker and the nurse practitioner on her, working with her, were able to find an organization that was willing to donate the materials needed to make her a ramp. And without that support, who knows when the next time she would have been able to leave her house to go to the doctors. You guys do a lot of special and meaningful tasks. It's not just looking at medications, it's thinking about and looking at the whole picture of how.
Absolutely. And I believe sometimes, when we get the referrals coming in, and I have sometimes a different way I look at things, and sometimes they may not meet the eligibility for palliative, but I always believe people deserve that admission visit because every case is different. And, there are times we'll go out there and it might be a one and done kind of thing, but you can go out there and look at it and see, okay, well, they do need maybe, door widening and, to fit their wheelchair through a door. Like what you said for a ramp, and maybe we can find a contractor that will be able to provide that ramp, or, it could be anything that we can provide those resources. Or getting them set up with long-term Medicaid to get the Meals on Wheels. There's so many things long-term Medicaid can provide for these patients that qualify.
Right.
So,
and when should you reach out for a palliative program?
Lots of times too, when your primary care office, when you see that the patient, if there's a chronic illness or if there's a lot of frequent hospitalizations, if you see, those are the times if you talk to a lot of the caseworkers or the nurses in the doctor's offices. And that's something, talking to Darlene Robinson, our supervisor, like if we can get a lot of outreach into these doctor's offices to bring in our referrals, those are the kind of patients that we need to target is the frequent hospitalizations and your chronic disease, like your CHF, your COPD, patients and stuff. Those are the ones that we need to go out and manage the symptom management. And then a lot of the times your cancer patients, who are still receiving treatment, nausea, pain management. We do a lot of pain management related that are still receiving the treatment that need the help in the home.
And a unique part about Delaware Palliative too is that anybody can make a referral. So whether it be a medical professional or a loved one or even the patient themselves can reach out to Delaware Palliative, set up the appointments, and what will happen at that point is we will reach out to your doctor to see if it is appropriate to move forward with the program. So it is, the program is, you are able to make a referral regardless of who's making that call.
Yeah, you do need a physician order. You can make the referral, and anybody can do that. It does need to come back to a physician, making needing the order for it.
All right. So let's sneak into hospice care and see what hospice is all about. So typically, people would look at hospice as end of life when you receive that diagnosis of a terminal illness. And what our hospice program does is really look at the whole picture. What are your goals? What are your needs? What do you want to accomplish? And Randy, could you speak to how you will help facilitate some of those goals and wishes?
For hospice, as far as the focus on managing pain and symptoms while improving the quality of life, pain management is the primary goal of hospice care, but people often have like a misconception about the end of life symptoms. For instance, relatives sometimes worry about their loved ones, what they consider being doped up, or someone addicted to strong pain medicines. They often have a fear their family member will suffer from severe pain or symptoms without sufficient relief. Hospice is about maximizing the patient's quality of life at each stage of their illness. That means finding the right balance between pain relief and the ability to live life. Hospice providers base their decisions on patients' needs and preferences. Near the end of life, patients may experience a range of discomforts, including pain, shortness of breath, nausea, anxiety, constipation, swelling, insomnia, among others. And the key goal of hospice care is to reduce those symptoms and increase the patient's comfort. Easing these symptoms enhances patients' well-being, enabling them to make the most of their remaining time. Hospice providers treat symptoms in various ways, from the use of certain medications to psychological and spiritual support. They also provide, caregiver training, companionship, which can also ease patients' discomfort, evaluating pain, which our hospice team is amazing with that. I'll tell you, we have the best nurses, and I've never worked for another hospice team, but I know just our team's amazing. The hospice team will assess the patient's pain during every visit. We use a pain rating scale. The pain rating scale, we use I don't know who's on the call as far as if we have nurses on the call, but we use a rating scale from 0 to 10 with no pain, and then the worst possible pain we use from like a 0 to 10 rating scale. And then we use pictures of smiley faces with different expressions. And then we use something called a FLAC score, which is a FLAC score evaluates the pain of using 5 different categories of nonverbal indicators of like face, legs, activity level, if the patient's crying. That's sort of how we evaluate their pain on observation. And then we also address their emotional and spiritual pain. This type of pain can increase physical pain, or vice versa. So some patients, those with like dementia, they're unable to communicate their pain sometimes. Others may try to hide their pain, fearing it will make them weak or not wanting to complain, among other reasons. So it's important for both family caregivers and hospice providers to watch for any of these indications of discomfort. Some of the pain can include, them breathing faster, tightly closing their eyes, rapid blinking, a rise in their blood pressure, holding their arms or leg muscles tightly, rocking. So, our nurses know when they're, starting to have the pain.
You spoke a little bit about observing the patient in whether they be in pain or checking in on them. how do you determine maybe the number of visits you might have, or who needs to go out, whether it's a nurse practitioner that needs to go out, or a social worker, or nursing, a CNA, a chaplain? How do you do all of that?
Well, the nurses typically evaluate that on the admission visit, at how frequent they're going to order a social worker or a CNA. Normally, sometimes that also varies visit to visit. That's sort of depending upon the nurse who they have as a case manager. They consider the nurse as a case manager. They sort of make that call. And then they check in with a provider who's on for that day to give the okay, on if they feel that that's appropriate. So they may have the CNA that comes out 2 times a week, 3 or 4 times a week, based on the patient's needs. So, as the patient's declining and not able to do much for themselves anymore, and also if the caregiver, it gets really, really burnt out. We have the center sometimes with the respite care that will go in and that's the center's there too for support. So,
Right.
If they just need to get in there to give the caregiver a break, that's needed. The center is amazing. So they will also provide care for symptom management. So if the pain is out of control, if the patient's having constipation, nausea, it could be anything. They go in and they sort of start all over and say, okay, let's look at the medications. Let's see what they're on. Let's see if we can get this under control. And then they send them back home and start all over again and see what we can do.
It sounds like that the case manager and the entire team, the interdisciplinary team, really looks at each patient individually. That it's not, a cookie cutter. This is what we're going to do. If the caregiver might need to go to the doctor, or them personally need to go to the doctor, or go get their hair cut. The case manager could help and bring in a volunteer to sit with that person, or if there's a spiritual, bring in the chaplain.
That's what I was just getting ready to get into, like spiritual, the patient's pet. There could be anything, massages, so many different things when you're dealing with, hospice and dealing with pain. There's so many different things emotionally that meets the needs of a patient going through the dying process that helps meet those needs. But what I was saying too, like with the medication part of it, the most prescribed medications too that we give is dexamethasone. It's also another medicine that we give that really helps with the pain, that helps with the appetite. That's the most prescribed medicine, one of the top medications that we do prescribe that helps with the appetite and nausea. Lorazepam, I don't know if you've heard much of that. That's another medication that we give that helps with the anxiety and agitation and shortness of breath. And also we'll give that to help with sleep. And then oxygen is another thing that helps, just a supplemental oxygen that can help with the healing. And that does help settle the patient sometimes. It's just giving a little bit of oxygen. And morphine is a big one that we use that helps with the breathing. If you see that they're breathing a little fast, sometimes the morphine helps control the pain, and it helps control the breathing and the respiratory rate.
You guys do a lot. You're doing
there's a lot of the nurses, and like I said, the CNAs and the whole team, the chaplains and the social workers, and you just go down with everybody. It's a team effort, right. What Delaware Hospice does, and just can't give everybody enough credit. Just how amazing they are.
And I think that one of the biggest things too about palliative and especially hospice is really the medication and the medicinal factors that go into both programs, but also the education that goes in for the patient as well as for the family members. Most families have never experienced hospice care or palliative care, and the education and the guidance that a palliative team and a hospice team can bring to the home is amazing. The Washington Post just came out with an article earlier this week talking about palliative care. And I just wanted to quote it because I thought it was a great quote. People in crisis do not have the headspace to learn new vocabulary. It is one of the medicine's major failings that it expects them to know this information. So all of you being on this call today, you know, you're taking this information in, and I know Mandy is a wealth of knowledge, and we could talk all day about palliative care and hospice care, but really starting to ask these questions when you go into your doctor's office, when you're visiting with Aunt Susie, and starting to feel where they might be thinking they're heading. So this slide shows the similarities of care. Think of palliative and hospice care as a big, it's lunchtime, so let's think of it as a big pie. And palliative care is a whole piece of pie, and a hospice care is one little slice of that. So there are a lot of similarities that go back and forth between the two programs. And Mandy, did you want to touch to any of the similarities?
Well, I do believe palliative care, especially the way I look at it, it's sort of like a feeder program to hospice care. So, you know, it's a chronic condition that it does. A lot of my patients do go to hospice. It does happen. I say that within a year or so, sometimes for the most part, they will transition over. There are some patients that stay that have been in palliative now for years and do well. So it all depends on how compliant they are with the medications and patient. So everybody's different on how they do.
Right, and that's an interesting point too, is that there are time limits between both of those programs. So one difference between palliative and hospice care is that palliative care, it's not surprising if the prognosis is 12 months or less to live, whereas hospice care is 6 months or less to live. But to Mandy's point, it's not uncommon for us to see people outlive and excel those requirements. We do have people that graduate from both of these programs. They have taken the education and the lessons that the staff members have taught them and have worked with them, and they are excelling and are doing well. And we have to graduate them, which is always an exciting day at Delaware Palliative and Delaware Hospice. But there are some significant differences between the programs. Mandy, did you wanted to just touch on a couple of them?
Yeah, like there are times if I go out and evaluate a patient, because I will tell you, palliative, we do not provide a lot of services. So we can be as absent or be as involved. Now I will go out if I feel that hospice is more appropriate, you know, because we provide the aides, we provide nursing, chaplains. I will recommend we bring in hospice, and I've done that multiple times. I just say, you know what, I think hospice will be more appropriate for you. And I will say that I do struggle sometimes, with that conversation. It's a hard conversation for me to bring up to the patient. I'm working on it because I've only been doing it about a year. So, but I will say it's, the hospice does have a little bit more, I believe they just have a little bit more of the services available as far as, you know, the aides, and they provide more care in the home for the patient. You know, the nursing and, like I said, with the aides and everything.
Now we do have a question from Cheryl. If anybody else has any questions, I know we're right at time, but we might take a couple minutes if anybody has any specific questions. Cheryl was asking, she was under the impression that hospice care has extended the 6-month time frame. Have you experienced that or heard anything like that?
Yes, well, a lot of patients I have seen, it's not really less than 6 months. I mean, that's what they sort of have said, the definition, 6 months less than live. But I really don't see many patients anymore. I feel like it's not 6 months or less anymore because, you know, doing the face-to-face certifications that we do, I feel a lot of patients now go beyond the 6 months that we have the certifications for. There's some that die, you know, much faster than that, but it will extend further than the 6 months.
So really calling,
still have the golden rule, 6 months less than, you know, that's the reputation it has. And I think that's what a lot of the stigma goes around. And that's why you mentioned hospice and people are like, oh my gosh, I have 6 months less than live. And it's not that. I feel like it has changed.
mm-hmm. And calling earlier has really made a difference as well. There's been several studies that have said, you know, bringing in a palliative care team or a hospice care team, you can extend the life of an individual.
Mm-hmm. You just got to do what's more appropriate for the patient. And that's the way I believe with everybody. It's what is the best care for the patient. So I just believe Delaware Hospice and Delaware Palliative. I think Delaware Hospice is an amazing program. So,
right. Does anybody have any other questions, or we can stay on afterwards if you have any specific questions relating to a topic? Vicki, we have one more, and then does the nurse practitioner serve as the patient's doctor?
For Delaware Hospice?
How about for either one? Let's take it for either one.
Well, no, they still have, for Delaware Palliative, they still have their primary physician in the field. We don't serve as their primary care doctor, no. We collaborate with their primary care doctor.
Okay. And how about for the hospice program?
For the hospice program, we have, yes, they do not have their primary care doctor anymore. So we actually are their primary physician when they come over into our program at Delaware Hospice. Mm-hmm.
All right. So let's.
Now there are some patients still. Now there are some patients that when they do come over in Delaware Hospice, there are some patients that will still randomly see their physicians, okay, but not much. It's okay. You give all your care to Delaware Hospice when you go over into the hospice care.
But if you choose, it's something. It's what's personal to you and what.
Yeah, but not many. It's normally when you go to Delaware Hospice, you give all your care, your specialists and everything. It's where everything stops. You don't receive any outside treatment or anything like that. Everything stops.
Okay. All right. Well, I know we're a little bit over. So I just wanted to share with you what's coming up in the next couple of weeks. Next week, we'll be putting pain in its place. And Mandy talked a little bit about that. Health when mom or dad come home from a facility. So we will be looking specifically at the caregiver and the impact of their health has on their on their loved one that comes home from a facility. In October, we'll be kicking off with staying fall free, getting into the fall feeling, but also making sure that when mom or dad does come home, that they are coming home to a safe environment. And then investing in your future. We'll round out October 8th. And then I know we have some exciting ones coming up towards later in the month. So please take a look at our website at delawarehospice.org for a full list of the lunch and learns that are coming up throughout September and October. And if you do have any questions, you're welcome to stay on and we can help talk through them. Or you're welcome to give us a call at 302-478-5707 or visit us online at delawarehospice.org or delawarepalliative.org. Our website has a plethora of information and resources and some new blogs that cover a variety of topics. So thank you. Oh, thank you to our corporate sponsors. Make sure we say thank you to them.
You're welcome, guys.
And thank you everyone for joining us today. I really appreciate it. Have a great afternoon.
Yeah, see ya. See ya, Jen.
Bye.
Bye. Now, how do I hang up for this? Just hit leave?